Hello, guys. Thank you for joining us, the Eyes on Glaucoma. Today, we're going to be doing a presentation called The Medically Minded. My name is Dr. Adam Ramsey. I am also joined by co-presentator here, Dr. Mary Ann Murphy. So today, we're going to be talking about glaucoma. This whole presentation is really going to be about how to get glaucoma done well in your practice, trying to get doctors more in line with thinking medically. A lot of doctors do a lot of vision and do a lot of routine care. And there is so much glaucoma coming into each and every one of our practices. And we're going to share some tools and tips and tricks today about how we have been practicing medically and trying to diagnose and treat glaucoma in our practice. And in some of my disclosures, I speak for some of these people, but that really won't influence too much of the presentation. This is from what I want to do, and this is what I love doing. So. All right, so what is the medical model and what is it not? So it is not for people that have an extensive amount of equipment. You don't have to have all the bells and whistles to practice medically, okay? Yes, it helps to practice medically, and I'm sure Mary Ann has a whole bunch of the toys in her practice, but she didn't start practicing that way when they got the toys. You start with wherever you are, and you add the toys as you go along.
Having the tools eventually, especially because so many of them are very operator friendly, so much more of that the staff can do. So then I'm left doing the things the doctor needs to do. So my time not only is, it's more efficient, it's better spent with the patient, and the data is all gathered for me. So in terms of doctor time, it's less time with the patient, but all the data is gathered by staff.
Yeah, I agree. It's not a headache. I actually like practicing medically because it kind of switches up my day a little bit. It can be a little monotonous just doing -2s all day. Yeah, I like it. It's easy. It's quick. But there's some fun in helping people. Depending on what it is, you definitely can make an impact in their life. And they're very appreciative. The people that I've helped through medical optometry have been more appreciative of the services and the care that I've given than anybody I've given a -2 pair of contacts to. Or some high index lenses. They like it, but they're not as appreciative as the ones that come in pain and they leave with no pain. They remember Dr. Ramsey a little bit more from the medical stuff than even the best pair of glasses. Would you agree?
I would agree, except I would probably play the flip side of that. And that is, as you mentioned, I definitely find my medical work more challenging than your typical -2 contact lens wearer, right? So I've never had a -2 contact lens wearer at the end of the day gave me a headache because my brain was smoking so much. But I've had plenty of glaucoma patients where I'm trying to figure out what's the next step. Is it a prostaglandin? I'm looking up their systemic meds and what's going to impact it. Do I do a beta blocker? I've definitely had my head spinning around those to the point where I've gone home exhausted, but by no means is it, frustrating or a pain in the butt or inconvenient in any way. It's the good kind of headache. It's the one that makes you realize your brain still works.
Now, when they tell you it's clear but not crisp,
right?
That is a headache. It's a -2. They read 2020. Dr. Ramsey, it's clear, but it's not crisp. I don't know how to explain it to you that I can see, TZV ECL, but it's just not sharp. Like that is a headache. So there's some headaches on both sides.
Okay,
just
fair.
choose your headache for the day. Okay.
Fair.
Expensive. The toys do rack up in price, but it doesn't have to be. And based on the presentations today, we're going to show you some ways in which it can be cost effective. And the toys should make you money. It shouldn't cost you money.
I agree with you there. I think if you use the resources that the vendors have to offer in terms of understanding billing and coding, understand what's bundled, understand telemedicine visits versus in-office visits and the proximity and time that they can have, there's a lot of information that you can gather about the proper way to do things to avoid the mistakes that could become costly over time.
Yes. So what it is a practice builder. Patients do come from all around because I heard you treat glaucoma. I heard you help with dry eye and allergies. I heard you help with this and you help with that, and you get to grow your practice from that. It is accessible to any doctor or practice, applicable to any patient, and we're doing the right thing. You know what I mean? The patient comes in for assistance and for help. And we're there, we see it, and it's just about us treating it. And then, people have fought really hard to allow us the ability to use our license to the fullest extent. And now that we're here, we have the training. I think it's up to us to actually utilize that and utilize that part of our brain and utilize that part of our practice.
I think it's a great opportunity, though, to reach out to your colleagues. I mean, your average glaucoma suspect doesn't need to go to an OMD. It needs to go to a medically minded optometrist that can sort out whether or not it requires intervention or it just needs routine following. So I know in Colorado, I have plenty of peers that practice in more refractive or commercial type settings and either don't have the time for this or it's not as profitable to them. And this has been an excellent way for us to expand our profession and reach out kind of elbow to elbow and share these patients. And then, I'm happy to send them back there for their routine care, but I love taking on that medical care for them.
I think the one thing that I liked the most when I started doing more medical was that I knew what an appropriate referral was and what it wasn't, and when I needed to refer and when I could hold. And I think when you get that confidence, that's the best feeling, because when I refer and they needed to be referred, then it's good. Nobody's mad. The patient isn't mad. I'm happy. The patient's happy. We're all good. But when I refer and it didn't need to be, and I could have handled it myself and the patient, especially the ones you have to refer, almost always have no insurance. And we're going to go through a few case examples today, and we'll see if you can learn a couple things. So, and if you have any questions, you can always ask at the end. All right, so another picture here. This is my practice here. So I love my Zeiss Claris machine. It gives me an ultra wide field image of the back of the eye, and I love being able to see both optic nerves at the same time, both maculas at the same time. Patients will come in and say, but this is the eye that's bothering you. I say, yeah, I know, but I want to look at this one. Not because I don't know that you told me this was the eye that was bothering me. It's because I want to know what your eye looked like unbothered. Because to you, red, and to me, red is two different things. But I do have, OCT, visual fields, topography, mammography, all the toys, and I bought some other toys at Vision Expo. So they get me every time. I go down there, they get me every time. But you know what? I'm happy with it. It expands. Sometimes when I think about my practice before I started adding in the bells and whistles, and I try to think, how did I practice before? And I get to see so much now that I'm debating if I either missed it or it wasn't there before. So I'm happy, and I don't think I could go back to practicing without the bells and whistles. How about you?
It would be tough. There's no question. I know that, like you, I've done quite a bit of charitable care. And, when you're used to practicing in a state-of-the-art setting like you have there and I have in my office, sometimes when I go to an inner city clinic or I go on a Vosh mission, gosh, you feel kind of handicapped because you are used to having all those bells and whistles. And at some point, I believe that I'm not providing the, care to the fullest of my ability. I want to be able to have an OCT. I want to be able, we do even charitable care for the community where, the local organization may only authorize a comprehensive exam. No additional testing is covered. I do it anyway. I'll eat the cost of it because I feel like in order to provide the level of care that I want to stand behind, I need that data. So once you've had it, it is hard to go back. And like you, I am a self-proclaimed gadget junkie. So if it exists, I probably have the alpha model, the beta model, and then finally purchase the ultimate, floor model. So spent a lot of money on this stuff, but I just believe it's worth it.
So Marion, I don't think the audience knows where you practice, and give us your rundown.
So I'm in a 5-doctor practice. It's an all-female practice. We're all part-time providers. So we all see patients 3 days a week, and the other days of the week, we're busy, in my case, running the practice. In the other 4 doctors' cases, they're busy being moms and being involved in charitable care and coaching soccer teams and working as paras in the classroom. And that has been a tremendous benefit for our practice because in lieu of any marketing, that drives a ton of patients with having the doctors out in the communities. I started as an associate at a small practice in Colorado, which is where I am now, and worked there for about 4 years until I started my practice cold. And I think, like Adam, I would agree. I think if there's an opportunity to start your practice warm, that's helpful. We've since grown. So I started by myself in a 1,200 square foot location. And after 4 years, moved to, in Colorado, space is a little bit different of a premium than it is in Florida. So sorry, Adam, but I'm in about 5,000 square feet now with 7 exam rooms, just totally different. And I did my training in California, where it's just unheard of, right? We have probably 35 parking spaces. So it's just something that's unheard of to people in other parts of the country. But I also have plenty of peers that practice in, Kansas and Nebraska that have offices twice the space of mine. So it's all, relative, but it's been a huge opportunity for us to be able to grow the practice and grow our presence in the community in terms of what optometry represents. In my office, multiple times a month, we have oculoplastics in our office. We have anterior seg, we have refractive surgeons at different times. We've also had different cosmetic procedures. We've had retina. And so it's been a full scope, one-stop shop where our patients could come and really get everything done. We have a great partner in binocular vision as well. So for me, it was, building the refractive side of the practice and then switching and kind of engaging in the medical model to continue to be able to serve the patients that we do. Someone told me really early on when I was starting my practice, I had really limited staff, and I felt like, oh my gosh, I at the time actually shared an OCT with 6 other offices. So once every 6 weeks, I would get this instrument. It was the only way I was going to be able to afford it. And so when that's every 6th week it came, we jammed in all of our patients who needed OCTs. But I felt like as the doctor, I don't know if it was because the equipment was so expensive, or I was just really selfish with the technology, or I didn't know how to manage my time efficiently. I'm sure it was all of the above. I felt like I needed to do every scan, and I needed to make sure that, that was the best possible scan. And if it wasn't just right, then I was going to have to redo it right then. But I very quickly learned in about a period of 6 months that that was not an efficient use of my time. So if there's one thing, and I know, Adam, you do this as well, but it's really helpful to utilize the resources of our vendors. And I know with Zeiss, anytime that we've purchased a new instrument from them, they've brought in a wonderful trainer. And we, whether we close down for a couple of hours or we just shift staff through, they will take the time to train my staff how to perform these scans. And the interfaces are so user-friendly that it can be a much better use of doctor time to have the staff focusing on doing the scans, whether you have a couple key staff members that run visual fields all day, or you have your OCT guru, or you have everybody cross-trained. But the more you can get staff to get good scans, the better your data will be, and the better your patient assessment will be, and the better your patient consultation will be. And it also affords you the opportunity, I know, Adam, you do this, where sometimes when you can't be in the office, they can come in and have the scans, and then you can communicate with the patient and do the consult over telemedicine.
What I've learned from taking in the information and the data is that garbage in, garbage out, and I'm only as good as the information I get. And the more I've educated my staff, the more they understand what they're doing. I tell them, I don't want a robot. I want somebody that's thinking. You know what I'm looking for. Do you see that on the screen? Like, make sure, I think educating our staff and taking that time is really, really important. All right, so in my office, before I even get the patient, I need to take the time to understand the case history, understand what the patient is coming in for. And I think sometimes you can gloss over medical history, and sometimes patients have written it all out. The puzzle is right there for you to look at. And I think most of us need to make sure we slow down and look at the history. Look at any questionnaire. So I use a dry eye questionnaire. You can also use a lifestyle questionnaire. Of course, the medical history, look at the medication. Sometimes patients will say, they'll write down metformin. And then if you ask them if they're diabetic, they say no. Because I'm taking my metformin, I'm not diabetic. My sugar is controlled. And I'm like, no, you're still diabetic. You just are on medication for that. So just slow down, make sure that we're looking at the case history, make sure we're looking at the medical history, and as you go along. And then this little tally mark thing here is what I have used from the very beginning, because whenever I go to the shows, I would see the visual fields and the OCTs and the clearance and all the different things that I love. And I try to figure out how can I make it work. You talked about splitting your OCT amongst other offices. So what I would do is every time a patient would come in my office that I could have run the test on, I put a tally mark. And I said, okay, this machine costs $500, $1,000, $1,500 a month. What am I going to get reimbursed for running that test? And then when I got to I tried to get about 25% more than I needed. That's when I said, okay, now I've averaged 3 months where I would have paid for this machine. So Adam, stop being scared. You already shown that you would have paid for the machine already. And I was surprised at how quickly I got to the point where I could have paid for the machine. So you talk about sharing the OCT with 6 other offices. How long did you share that OCT?
I was sharing it for probably 9 months.
9 months. And then after 9 months, you got it yourself?
Yep.
So that's the same thing. You're looking at it, you're like, oh, I don't think I can do it. I don't think I can do it. And then 9 months later, you're like, I need to have this in my office all the time. I can't be sharing this around. Now that did give you an opportunity to test it out and test the waters a little bit. You can do that same thing for 3 to 6 months with my tally system that you did with sharing the machine, to figure out that, you know what, I can afford this, I can do it. And I think writing it down is better because you'll visually see the usage and how often it is. Sometimes in your head, you underestimate how many glaucoma suspects or how many macular degeneration or how much drusen or how many epiretinal membranes or whatever that have come into the office than you actually have. So I utilize the tally system and definitely use case history or questionnaires. Do you use these things in your office, Marianne?
I have a case history and questionnaires that we use, and then we have a detailed family history one too to determine if genetic testing is necessary. So both of those.
All right. So this is my thing. Never skip simplicity for complexity. And sometimes the smallest simple things that you already have in your practice is all you need to get started. Now, of course, we love all the toys and the bells and the whistles at the end. But with glaucoma, if you know their eye pressure, you know their angle is open or closed, and you know their corneal thickness, that does give you a start. And almost all of us in school, they made us get a gonioscopy lens and stuff like that. Almost we all can test with Goldman acclimation in our office. Most of us have, even if it's an old school pachymeter, we have pachymetry in the practice. And sometimes we can, get all the bells and whistles, but just start with the simple stuff. Start with the basics, and then you grow to the other more advanced options. But start with wherever you are, whatever you have, and then you grow from there. The simple and the basic is a great start. Never skip over that. Now, in my office, I do have the Zeiss Claris machine, and this is an accurate depiction of the picture we get. Now, the staff are really trained very well on taking the picture and being able to see really far out and getting a global view of the back of the eye is really imperative. Glaucoma or no glaucoma, being able to get a global picture of what the eye is instead of small segmented zones of the eye does give me some comfort and relief when I'm trying to diagnose and I'm trying to figure out what's going on with this patient. What I also use is that some people never even talk about this, but there's an anterior seg function on that Claris where you can take a picture of the front of the eye. And I take a picture of the front on everybody's eye. The same way we take a picture of the posterior pole, I take a picture on the front, because what happens when you start putting prostaglandins on a glaucoma patient, those eyes get red, those lashes grow. And I like to see the before and after and the effects of that. And that's also a billable photo for one, but for two, that I also get the information of how that medication is affecting the eye, because there is an effect to prostaglandins. Lashes growing, eye redness. When the patient is complaining about the eye being red, it's great to have a picture of before I started them on the medication to see, are they really getting that red because of the medication, or were their eyes always red and they just complaining to me today? So I like having that. What about you?
Yeah, I have a separate slit lamp based anterior segment imager that I'll use. And then in my office, just in terms of technology, I think some of the most useful things when it comes to glaucoma for me are the OCT, no question. And for me, I use Forum because to me, having all of the images and all of the data in one place really makes my consult efficient.
Okay, yeah. Now these OCTs with this HD analysis here, why that is a piece of technology that you almost can't go without. Once you've been able to see that kind of detail of the retina, it is hard to go, because now you look at it and you're like, I would love to get a B scan of that. That'd be really good to get. But the details and the stuff matters. People always talk, when you talk about OCT and photos, that you can't do them on the same day. You can't do them on the same day for the same diagnosis. But that does not mean somebody does not have diabetes and glaucoma at the same time. So you guys there is a way. If you can figure it out, you can write it down. There is a way to make these things work for you and your practice. Visual fields. I still like a visual field. I love OCTs. I love it there, but I like to see that person click. I want to be able to see what's going on and see how their functional vision is actually being affected as well. So all the toys are there, and never give up on the basics. So the Humphrey visual field is still something that I love to have in my practice.
And yeah, if I can add to that, because we have a lot of patients whose care is transitioned into our office, and they're either moving here or insurance reasons or whatnot, seeking different care. And a lot of times I'll see that those patients will have had, repeated OCTs, maybe every 6 months, serial OCT, which is fantastic. But then I'll look at the data there. I'll call the other office. I'll ask the patient, when's the last time you had a visual field? And even as you're describing the instrument, which there's no mistaking which instrument it is, patients know if they've had it, they say, oh, I think I had one of those 5 years ago or 10 years ago. But to me, when it comes to glaucoma, the visual field is still the standard of care. I would argue it's becoming OCT, but in the end, what matters is functional vision. If I can tell a patient till I'm blue in the face that structurally you're losing tissue, if I don't know if they're losing vision, we don't know how it impacts their life. So I think having both of those and running them continuously is really, really critical to good patient care. So I'm glad that you said that.
Yeah, and patients get better at doing the test when they have to do it more often. If you make them do it every 5 years, the test is not going to be that good. But if they're doing it every 3, 6 months, whatever, whenever they come into your practice and whenever is medically necessary, they get better at the test, and it gives you some more validity to the testing. So have them do it regularly. There is something to be shown to show the patient, hey, you are losing vision. I asked you to put these drops in twice a day and you're not listening. And showing them this is your vision a year ago and this is your vision today, it has a lot more of an impact. I would also say, so I use color vision testing. I use gonioscopy. And also, I love looking at the optic nerve and zooming in. That's one thing. Before I had a fundus camera, you would be able to look and you click it up, but it's not the same as I can sit down there and zoom in. A lot of times I see patients in my practice, and then at the end, when I go back through the charts, I'll click back through the images. I'll click back through the OCT with nobody else in the room and just give me a chance to sit down there with my thoughts, especially in a challenging case. And that's something that you cannot do if the patient's no longer there. But now when you have the technology, sometimes I can look and sometimes I'll see something that I thought I looked really closely at, but I didn't see it as well as I would like. And then when they leave, I look back and I zoom back in, and maybe I changed the medication, or maybe I changed my diagnosis, or I changed something in there. So being able to sit down there and look at it is some of the great thing about having this definitely great technology. So yeah, with COVID, there's some things that have stayed and some things that are going to go away. But I think having those big shields on my forearm, on my slit lamp, it's still going to be there for me after it's over. We're all going to laugh about practicing during COVID, and we're going to go back and be like, remember that year we had to do all that crazy stuff? And some of it's going to stay and some of it's going to go. But no matter what, practicing medically is still going to stay. And that's going to be one of the things that's going to continue throughout our years.
We both practiced medically before, but the opportunity to use the telemedicine platform also to communicate with patients. During COVID, you could only have one person in the room. I think diseases like glaucoma can be family diseases. Just talking to a woman about it, she oftentimes wants her husband there. You've got patients who have questions. During COVID, we didn't have the flexibility to do that. So getting on telemedicine, or now it happens during the workday. Wife is at work. They want to talk about it later when he gets off after 5. I'll jump on with telemedicine so I can have both people in the office. I can screen share. And that's, again, the advantage of having some of the data analytical tools that are really user-friendly for both the doctor and the patient to understand. I can share screen and go over some of that data with the patient, and I'll show some of those examples here in a minute.
And the hard thing is when you have the mask on, sometimes patients can't get the same connection because they're not seeing your face and facial expressions. And with the telemedicine platforms, you're able to take that mask off and talk and be yourself, and really connect with that patient. And like you said, connect with the family members at the same time. So sometimes we'll do the testing and I'll do some follow-ups afterwards through a telemedicine platform. And I think being able to show them all those bells and whistles and toys. And I've gotten more patients from that than anything, because the partner, the wife or the husband is like, oh, they did all that stuff on you? Oh, I need to get my eyes checked. I've never had anybody do any of those things on me. So But now let's go ahead and take a look at some of these cases and see some of these toys ourselves. So this is one of my patients that came in a year ago, a 53-year-old African-American female, and she was complaining about pressure in the back of her eyes for about 6 weeks, on and off. So, you know, patients call and they write everything, and I'm seeing it on chief complaint. I saw it when she made the appointment. They put a little note, pressure behind my eyes, pressure behind my eyes. And we get this pretty regularly. People always say I have pressure. Sometimes you try to write it off as dry eye. Sometimes you try to write it off as a lot of things. But I'm like, okay, well, you need to come in. I can't do anything for you over the phone. I need you to actually come in and let's take a look. Her vision was fine. So throughout the test, we were able to check and see her vision was actually fine. But then all of a sudden we did the affirmation and her eye pressure was elevated. So I was like, okay, you are having some pressure issues there. Let's try and figure out the actual cause or diagnosis for that increased eye pressure. So that's when I had the staff go and do some of the bells and whistles toys here. And the great thing about having a wellness scan of the eyes is you get to look at everything. You know, I love looking at a B scan. I love looking at the macula right away. I love looking, you know, macular thickness. I love looking at the OCT all around. That's a good thing about the wellness scan. I've included a wellness scan on all of my exams. So every patient gets an OCT, even if you're coming in for a visual complaint, they're getting a wellness scan of the eye, and I'm able to diagnose and look better. And a lot of times I can pull out a patient that would have just been a vision issue, and I can pull them into now returning back for a medical visit because of these wellness scans that I get to do with every patient every time. Now, do you do a screening OCT on your patients in your practice?
We do not. I know a lot of people have used this model, but we do it strictly kind of vision-based, medical-based, so we keep them separate.
You can make this successful either way. Patients love it. For me, I like showing it to them. I like seeing it, and it gives me some more confidence. And then after that, I had them do a angle assessment here, and then all of a sudden, look right here. These angles are closing up on us right here. So these angles are really tight here. So I also had them do a pachymetry analysis here, and then when I look in the back of the eye, look at that optic nerve. So of course you see some diabetic retinopathy as well in this photograph, but I had a textbook case here of angle closure, and her angles were closing up, which is why she was saying she was getting intermittent pressure increases, and she was getting that pain and pressure behind her eyes that she'd been experiencing for a while, and had been either not diagnosed. She said she's mentioned it to other people and other doctors in the past, and maybe the day she went in, the angles was open that day. Maybe her eye pressure was not elevated the day of the exam, whatever it is. But I was able to see that in the exam, being able to look at the technology and be able to view it and show the patient. Because once you show the patient, hey, this is supposed to be open right here, there's supposed to be a gap right here, and you show them that it closes up on you, they definitely are more apt to go along with your treatment, go along with your treatment plans. And then when you tell them, hey, I need you to see this person, I need you to do this, they understand exactly. And they're like, thank you for being the one that actually saw and understood what was going on with me and in my eye. And I love
would
being
reiterate
able to.
that. Yeah, I think that's so important, Adam, what you said, which is this data, you know, was designed primarily for us to make the diagnosis of glaucoma, but I think it is equally as important for the patient to see it. And when we look at some of the serial data that we can connect with this instrumentation, patients watching how that changes over time really, to me, allows them to own the disease and own compliance with medication and own follow-ups. And when they see kind of the graphs of how things progress over time and see these angles closing and understand what's happening, it allows them to own the follow-up for it as well. So I think that's really critical, where you could describe it till you're blue in the face, but when you see a picture of it, there's no question what it is.
I love showing the images and asking the patient, what's the difference between these two? So I have a 0.4 CD and a 0.75, and she'll be like, oh, that thing's bigger right there. Like, what's that? And then I'll say, what's up with this and what's up with that? And they're like, yeah, what are these little red dots over here? And that's your diabetes, ma'am. I've been telling you, got to get your sugar under control, and you're not listening. And I know it's Thanksgiving and I know it's Christmas, but there is a negative effect to that. And getting them to connect to it, they come back and say, can I see that again? I want to see my picture again. I want to see my eye again. Because they remember, sometimes even if I don't remember, and there was a little peripheral bleed out there, and it's, you know, really far in the periphery. And the patient will come back and she'll be like, is that little spot still there? Is that little bleed still there? And I'll be like, yeah, let me check. Yeah, oh, no, it's gone. She said, yes, I've been really controlling my A1C down. It's down to 6.1. You know, I've been really working on it since she talked to me about that. And now they have become in control of their own health. They're coming and they're more engaged in the process. So the technology is great, but I think it also is just equally as good to educate the patient and allow them to understand the disease process that, you know, glaucoma, it has a negative effect later on. In the beginning, they don't get it. If their eyes are not in pain, if their angles are open, they can have an eye pressure of 30 and not feel anything. So we're the ones telling them they have glaucoma. They feel like they're fine. I can see, I can drive, I can read. I just need some new glasses, Dr. Ramsey. Like, you're telling me about all this other stuff. I came to get some new Gucci glasses. Like, I did not come for all the other stuff. But now when they can see it and they can understand, then all of a sudden they buy in a lot more. So that's why I love the technology of being able to a patient education tool as much as it's an information gatherer for us.
You know, all of us have been trained how to detect glaucoma, how to treat glaucoma. So I really want to spend just some time talking about the data analysis tools that we have through our partners at Zeiss. And so while this is as much a feature of the instrumentation, it's also a highlight of some of the software that we can use to really help us in data gathering, progression analysis, and then, like Adam said, communication with the patient. So this one pretty straightforward. This is a 75-year-old white male. He had I had diagnosed him with glaucoma a couple of years ago. Like Adam said, we don't do any screening tests, but my initial evaluation showed his cup to disc ratio in that right eye was slightly bigger than the left eye. He also had a positive family history, but his pressures were normal. But based on OCT analysis or optic nerve head analysis here, you can see he's got some tissue loss in that right eye. And you know what I like about this one, again, and you guys are all used to going through these, but I describe this as a heat map to the patient, showing where that tissue should be, like walking into a room with night vision goggles on, and I can see where that tissue is, where it's supposed to be and where it's not, that this compares them to normal. And anytime that there's color there, that we know that there's some variation, I tell them this is a dummy proof analysis for me. Green is good, yellow is not so good, red is definitely concerning. And so when that doesn't take much more than that. They look at this and they're like, why is there yellow and red on there, right? So we know that we have to get engaged and we have to do some follow-up. You'll next obviously typically use this guided progression analysis. And what I love about this, as you know, is like you're going to get 2 baseline scans from the first 2 times you do the scan. This was early on, so this is 2015, 2016, these scans done a year apart. I typically like to do my 2 initial baseline scans within 6 months of each other, but it does take and data lock those 2. And then you have the opportunity to compare all of them. And so you can see here on this right eye, we've got baseline 1, baseline 2, and now we're actually at exam 6 and exam 7 in 2020 and 2021. So it has also data registered everything in between, but it's using the most 2 current scans and comparing them to baseline. And then down here, obviously, what we've got is the thickness graph. So on the x-axis, you've got the patient's age, and on the y-axis, you've got the thickness in microns. And what I love with these, again, very straightforward to the patient. I'll say, these 3 right here, we don't want the line to go down. This one over here, we don't want the line to go up. And like Adam said, they look at it and they're like, but wait, those lines are going down. Exactly. That's a problem. We need to, we need different intervention here. And the same thing, to me, there's a part of glaucoma that is, you have glaucoma and I recommend treatment. But like Adam said, that patient needs to own the treatment. And so if I tell the patient they need treatment, but they're not symptomatic, they don't want to take medicine, they don't believe it, it's a choice we have to make together. And I'd much rather know they're not compliant with their treatment than thinking that they are and something I'm doing is going wrong. So I may tell a patient here, I'm looking at the slope of this line of your average RNFL thickness. And what I don't want to have happen is I don't want this to drop below the 70 micron mark when you're still alive. Well, if someone's looking at this and the slope of the line is really shallow and they think it's not going to drop below the 70 micron mark until they're 120, well, then we decide together that maybe intervention isn't necessary. But if we decide that the slope of the line is steep enough and it's going to cross that 70 micron mark at age 81, they are very much alive and well at that point. And so what we do for intervention to change the steepness of that slope will be a factor of kind of what happens once the intervention begins. So again, with this, what you get with this analysis is the time progression for the average thickness, superior, inferior, and then average cup to disc ratio. You get the thickness profile, so baseline 1 being the dotted, baseline 2 the solid, and then the current being the blue line. And then again, some dummy proof analysis here for me, which just tells me where there's possible loss, likely loss, and here it says possible increase. We know it's not typical to have an increase, but sometimes you'll have a scan that just doesn't register appropriately. And then the same thing over here on this left eye, you can see those things. And then here again, just very subtly, you know, if you have someone who has a really unusual optic nerve, if you're comparing them to normal, they're always going to be abnormal. I always say, you know, I have a daughter who's fully grown at 4'11". If I keep comparing her to normal people, she's always going to be abnormal. But if I keep looking at her and saying, okay, well, she's 4'11" every year, at least she's not shrinking, we win, right? So this one here, I'm no longer in these two comparing it to normal, but rather comparing it to the previous scans and comparing it to baseline. And I think when patients see that, it gives them a lot of really useful data. So that's just the scans of the optic nerve. You know, again, more recently in the last couple of years, been able to do ganglion cell analysis. This one is just the straightforward image of the ganglion cell analysis. And then the same kind of thing. Once you have registered 3 of these scans, you'll get gross progression analysis of these as well. And you saw in Dr. Ramsey's scan where he actually had the 2 kind of combined in one. And so it is nice to see it on a wellness exam where you can see it all together. On this same patient, the other test that we typically do, again, visual field. Everyone's used to looking at these. I don't need to go over these, but these are the standard kind of data generation that you're going to get from the visual field, which I think is important for patients to see. But this is one of the advantages of form where you can have all of this in front of the patient, where in this one here, this is just a right eye overview, right? So this is giving me the last 3 fields this patient has done: March 2019, June 2019, April 2021. And I can see them at a glance without having to flash between different screens or use different software or go in and out of different data analysis platforms. So I like being able to see it here all at once. And then this one is actually a gross progression analysis of the visual field. And I think where sometimes people get a little bit lost in this one is on this right eye here. Can you see my pointer?
Yes.
Okay, so obviously you've got the grayscale deviation here, your threshold deviation. This is your total deviation, and then the pattern here. And the same happens here. But what's important to note with this title here is that these are, again, both your registered baseline scans. So the first 2 scans that we did for the patient. You'll notice on this GP analysis here, they're actually circled. It's hard to see because they're so close together. But those are considered your baselines like we're used to using in OCT ONH analysis. And then over here is now the follow-up. So with this one, they're in a little bit different order. You've still got your grayscale here, but now this one is your pattern deviation. So that corresponds to these here. And then you've got this beautiful one here, which is your deviation from baseline. So this one is not deviation from normal. This is just deviation from baseline. So taking the combined data from these other 2, comparing it. And then this one is really the progression analysis. So you can see we've got different symbols here with a key down towards the bottom that tells us what is the statistical probability that we've got deterioration there that's real. So again, this is another really useful tool with the patient. And then it takes that visual field index here and plots it on this scale. So with this particular patient in the recent years, just 3, but as you get more and more data from the patient, again, we get an opportunity to draw a wonderful line here that the patient can have some impact over. So these progression analysis, I think, are really a valuable tool of the Zeiss Forum software. So then this one's just, again, the left eye overview. So you've got 3 different analysis there. And then this is the progression analysis on the left eye. And here again, you have the ability, you can see there's 4 on this one. And that's because on this day we did 2 tests. We initially did this one, but we had low test reliability and everything looked clean here. So then we repeated the test because we had fixation losses here. So we repeated the test and got a little bit more reliable data. So you can pick and choose when you're in Forum which ones you want to include in the analysis. And that's why here you're going to get 2 data points. But anytime you do repeated tests on the same day, which you can bill for, like Adam mentioned, it is helpful to be able to see them all at once. And then this is probably one of my favorites. Now, this is at one point in time, but for this particular patient, you just have it all on one screen. So this is oftentimes one that I'll use when I'm closing out a telemedicine visit, where I'm showing them all of their visual field data from this time for both eyes, also looking at the ganglion cell analysis, the nerve analysis, the clock hour analysis, the quadrant analysis, and again, right back down to it here, we've got yellow and red that we need to be watching to make sure that we don't have progression of those. And I didn't show obviously all of the details that goes along with these, because for each of these scans, there's typically, again, that second and third page, which give the numerical data associated with it as well. I think that can be a little bit overwhelming for the patient. So again, once the staff performs that test, oftentimes I'm in the exam room looking at the raw data analysis and then using these beautiful overviews to show to the patient. So that one's just kind of a real simple case overview of data that we can use in Forum. And then like Adam mentioned, one of the advantages of the Cirrus 5000 is the availability of the lenses, the corneal and anterior segment lenses. So with these two attachments here, which you apply simply to this lens right here, you get additional information related to, in the cornea one, you can use that obviously for evaluating your specialty lenses, looking at corneal vaulting, looking at corneal pachymetry, and the anterior chamber one, which is my favorite because like Adam had in his case, a case of narrow angles. This one was 2019, so this is before a software upgrade where basically you could take a wide angle chamber analysis where you'd go side to side, and then there's some tools in the software that allow you to actually go in there and kind of put in a little protractor to measure what those angles are. And then up at the top here, it's going to record those for you, and that data can be transmitted to your software. So this is a simple scan of a patient's left eye. But in the more recent upgrade, one of the other things that you're going to get is this scan here. So it gives us a little bit more data, and we can look here at a couple different pieces. It has a little bit more detailed measurement where some of that it'll do automatically, giving you measurements of the iridocorneal angle there. And then you've also got what you've got represented here is this angle opening distance. And then you've also got the trabecular iris space. So this is some functionality that we have with the Cirrus 5000 as well. So this is a wonderful one to show people when you're concerned about narrow angles, when you're recommending something like a peripheral iridotomy and or contemplating cataract surgery, because you've got the combination of cataracts along with those narrow angles. And you can do these scans kind of pre-PI or pre-cataract surgery, and again, post-cataract surgery, and patients really see that difference there and understand the impact that it's had on their vision. So having this technology in the office along with fundus imaging, like Adam shared there, has been an extremely useful tool in not only being able to diagnose and manage glaucoma as a doctor, but really in terms of patient communication, patient ownership of the disease and of the condition, and sticking to the follow-up appointments. One last piece I'll add, Adam, before we get ready to close out is, you know, we typically have, and I think you do too, student interns in our office, whether they're coming from optometry school or we have high school students sometimes that will be shadowing us. And sometimes we just have less busy staff members, okay? So we use data mining in our software extensively. So if someone is sitting around, I will say, go to our software, go to our EHR, you can search by diagnosis. I want a list of the last 6 months of glaucoma patients. And the beautiful thing about Forum is when you pull them up in Forum, it has a really nice grid of when they had each test last. And so I said, if we have a glaucoma patient that we haven't done a visual field in over a year, you're calling those patients, you're getting them scheduled. And so it's a combination of the data that we're able to extract from our EHR, along with the easy presentation of the testing grid in Forum. We can correlate that data and really make sure that we're keeping a good eye on our patients, because let's be honest, you can tell them to come back, but it gets to be really difficult over time to make sure that they do. So having another way of using that checks and balances system where the software systems work together is a really fantastic advantage of the Forum software. And the last thing I'll add to that is, it is great. I mean, I love that Forum ties together all of my Zeiss data, but I also like having one data management system. So Forum does have the capacity to hold data from other instruments as well. So for instance, I use an Oculus for dry eye, and it'll take the Oculus data and store it there as well. So it's not just for glaucoma, it's not just for Zeiss. The Zeiss instruments fold into it seamlessly, but if you have instruments that are, you know, outside of Zeiss's purview of specialty, it can hold data from those instruments as well.
That is wonderful. All right, well, thank you guys for tuning in. The Medically Minded Eyes on Glaucoma. This has been a great time. I've enjoyed it. I've learned something. I always try to learn something. I've learned something from Marianne. She gave me a few tips and tricks there that I'm going to be able to use in my practice. So how was it for you?
Adam, I always love spending time with you. Thanks again. And thanks to all of you for spending your time with us this Saturday. And if you have any additional questions or want a demo of some of the Zeiss equipment, please reach out to your reps because they're more than willing to do that either virtually or in office with you. Get your staff excited like Adam did when he took them to Vision Expo. Make sure everyone's engaged and have tons of fun with it.